Hello everyone, welcome to QAxon. So in this video, you will learn about nerve injury. Under this topic, I will first discuss some important causes of nerve injury, followed by the clinical classification of nerve injury. But most importantly, we will discuss what happens at a microscopic level, that is the process of degeneration and regeneration. And we will also talk about a couple of tests done in the context of nerve injury. So here we go. Now, when we think of the causes of nerve injury, what instantly comes into mind is some kind of physical trauma, for example, an accident. But there are many other causes of nerve injury. For instance, compression or stretching of a nerve, as happens in carpal tunnel syndrome, could cause nerve injury. Even more commonly, ischemia, that is reduced blood supply to a nerve, can cause injury. Of course, contusion or crush injuries and lacerations are important causes. Sometimes certain chemicals could also cause toxic damage to nerves. Even alcohol is a recognized cause of neuropathy. Deficiencies such as B12 deficiency can cause peripheral neuropathy. And of course, we know that infections like leprosy tend to affect peripheral nerves. Now, when a patient presents with nerve injury, it is very important to assess the severity. In this regard, Sunderland's classification of nerve injury is very useful. So, based on this, you can classify nerve injury as neuropraxia or first degree injury, which is the least severe. This is only a functional injury. More severe forms include second degree injury or axonotmesis, third degree injury, fourth degree injury, and the most severe one, that is neuronotmesis, where the entire nerve is sectioned. So neuropraxia is the least severe of the injuries, and this is because it is a purely functional injury. There is no damage to the structure of the nerve, and therefore there are no degenerative changes. Now, to give an example of neuropraxia, sometimes there is fluid collection in a limb, so the nerve is compressed. Now, in the initial stages, there is only functional injury to the nerve. So if you relieve the compression, this injury can be reversed. Therefore, in neuropraxia, recovery is quick and complete. But if you look at second degree nerve injury or axonotmesis, there is structural damage to the nerve. So if this is the axon, then the axon is cut or severed. But the endoneurium within which this axon is housed is intact. So in axonotmesis, the axon is severed, but the endoneurium is intact. There is, of course, some amount of degeneration, but overall the prognosis is good, and though recovery may take a few months, it is often complete. So how is third degree injury different? Now here the axon and the endoneurium are severed, but the perineurium is intact. Of course, there is degeneration and there is also a lot of scarring, though it is not as severe as a fourth degree injury. And because of this, recovery takes a long time and is often not complete. Sometimes there could even be misdirected regeneration. So what do we mean by misdirected regeneration? Now imagine this is the severed axon. So this is supposed to make contact with this tissue. But during regeneration, sometimes it can deviate from its track and make contact with another tissue aberrantly. So this is called misdirected regeneration. So fourth degree injury is much more severe and involves sectioning of the axon, endoneurium and perineurium. The epineurium is intact. Now here there is intense scarring, and sometimes this results in the formation of a mass that we call neuroma. Therefore, recovery is very limited in fourth-degree injury and often requires surgical intervention. The most severe form of injury is neuronormesis. So here, the entire nerve is sectioned and the epineurium is also cut. So chances of recovery are very slim, and this always requires surgical intervention. Now, from a physiological perspective, we are much more interested in the microscopic processes that occur in response to nerve injury. Now, there are two important processes that we study here, that is degeneration and regeneration. So let's use this diagram to understand these processes. Now, you can see in the first diagram, this is a nerve and it is supplying a muscle. So the muscle is the target tissue here. Now, this is the site of injury. So the nerve is sectioned here, and that divides this nerve into two portions. So this segment is called the distal segment, and this is the proximal segment. Now, the degenerative changes which occur in the distal segment are referred to as Wallerian degeneration, whereas the degenerative changes occurring in the proximal segment are referred to as retrograde degeneration. So what happens in Wallerian degeneration? Now look at the second diagram. So this is a few hours after the nerve injury. So you can see that the axon terminal has retracted from the muscle tissue. Therefore, the muscle becomes paralyzed. Also, you can see that the axon is now more swollen. And slowly, the Schwann cells break down the axon and the myelin into small rodlets, and eventually they phagocytize this portion. Whereas if you look at retrograde degeneration, you can see that after injury, the soma progressively swells up. You can also see that the nucleus swells up and starts moving to the periphery. And eventually, the Nissl granules disappear. So these are part of retrograde degeneration. Now in this diagram, you can see that the process of degeneration is complete. There are no remnants of the axon or the myelin. All you have is an empty tube lined by Schwann cells. So this empty tube is called the ghost tube. Now in this diagram, you can also see that the process of regeneration has begun in the proximal segment. Now this is very similar to when we cut the stem of a plant. You see that after a few days, there are small buds sprouting out from the proximal stump. That is the power of life. So the same applies to the neuron as well. You can see that from the proximal stump, there are small sprouts coming out. Now initially there are multiple axon sprouts, and three-dimensionally they give the appearance of a cone. So we call this as the growth cone. Now all of them grow, but only one manages to enter the ghost tube. So once this happens, the others degenerate. Now the one which has entered the ghost tube, it grows very slowly and eventually makes contact with the target tissue. So you can see in the last diagram that the neuron is restored to its original structure. You can see the myelinated axon. It has made contact with the target tissue, and the soma is back to what it was. The only difference is that often the diameter of this axon may not be the same as before. It may be lesser, and therefore the conduction velocity may be reduced. Now this would depend on the severity of the initial injury.